you so much, and thank you all for, as Sherry said, for participating today. We're actually going to have then a follow-up call next week at the same time, so you can have some time to digest what I bring to you today, and I want to allow some time at the end to have some question and answer and dialogue, and then again to have some, the next couple of days to have you think about it, and then have more robust discussion next Friday as well. And again, this is, doesn't have to be, just 2 sessions, obviously, but I think this will be a good start. So as Sherry said, I am with PCA Network Relations with NAC. I've been here a little over 2 years, and prior to my time here, I have actually worked for 3 different managed care companies over the span of 20 years. The majority of that time was with 2 plans in Pennsylvania, Geisinger Health Plan, as well as UPMC Health Plan out of Pittsburgh. So both of those, I was in the network relations department, did network development. I was the person that you would be talking to and discussing the exact same things that you're being asked to look at and talk about today. So, I can give you insight into certain things, and obviously, we're in an era now from a health center perspective that is seems very fast. But I think that between what your PCA is doing and moving forward as an entity yourselves, individually as well as part of the state, I think you're going to be able to position yourselves very well in this new environment. So with that being said, okay, here we go. So yeah? Oh. Okay. So the agenda of what I wanted to, these are just the high-level areas. How did we get where we are right now? Understanding managed care organizations, the preparation, and this is really what I want to really spend a lot of time in, and then the demonstrating of the value of health centers, and then end with some discussion and Q&A. So just to give you a bit of a landscape nationwide, we as health centers are seeing our uninsured rate going down. Right now it's around 35%, but we do know that that's continuously trending downward. Medicaid is going up, and especially as more states such as Pennsylvania have moved from non-expansion to expansion. The commercial rates are staying, and within your commercial, you will find your exchange plans, your employer plans, and then your Medicare. Now, the Medicare rate, depending upon where you are in Pennsylvania, you probably are going to be seeing, and if you participate in a Medicare Advantage plan, that average of 8% may be very low compared to what you're seeing. One of the things I will advise, and I always advise when I'm talking to health centers, is you report every year your demographics on your UDS information. You should be monitoring that and trending that and looking over the last number of years to see exactly where your patients fall that you're treating. Because if you're seeing these numbers, these numbers tell a story. These tell a story nationwide. These numbers are going to tell a story for you, and it's going to also be an effective tool to use in negotiations or to decide whether or not this particular contract and relationship is a good fit or continues to be a good fit. So one of the things that, and what this slide is really saying, is from a provider standpoint, and I understand that, within Pennsylvania, you're moving from a technically a fee-for-service into your the PPS rate for your Medicaid patients, but very few instances where providers are quote-unquote dinged, or a portion of if the patient, so basically a patient comes in, you see that patient, you treat them, you send in a claim or you do something to get payment for that, and if the patient doesn't do what you advise them to do, or if they do go in for a lab test, or let's say a mammogram or a colorectal screening, and it turns out that there is an issue clinically, you're not dinged for that. So when we're talking about value-based payment, that's what we're talking about. We're talking about moving from just the face-to-face to what actually happens or doesn't happen after that visit and continues on with that care for that patient. On the opposite side is an understanding of Medicare and Medicaid managed care plans. Regardless of whether your state has been in a expansion mode or not, for Medicaid managed care and Medicare Advantage plans, they receive, the managed care companies actually receive a dollar amount or a premium amount that's set. And different factors go into that, but they receive that for their members, and then it's up to them to take that dollar amount and, number one, make sure that they are actually covering certain benefits. They have to cover a minimum of what Medicaid or Medicare would have covered in their own right, in their own as their own payer, but they do use additional dollars to actually make those more robust, and that's why you will see where if you had, let's say, 10 Medicare Advantage plans at one point a couple of years ago in your area, whether you participated or not, but that were available to your patients, your Medicare patients, and now maybe that is down to about half of that, or maybe about 5. What happens is that's one of the reasons it becomes too expensive to actually be able to be able to cover those benefits and to do it effectively and to impact patient care positively. So what's happened, and this has been for a number of years, the health plans, their payment has actually been tied to value. So if you are familiar with the HEDIS and the STARS, which the STARS is just the HEDIS plus a couple of other measures that are for the Medicare population, these are what the health plans have to report on, and it's based on claims data. So it's information that they have to report, and it also determines how sick or what the quote-unquote risk of the population is that they are serving. So there's a continuous loop that happens within this, and I'm hoping by the end of this you'll understand that a little bit better. So that's why we have to make sure, and then most recently is that next to last bullet point is the poor customer service or the CAP survey. Those are, that's why, and as you know, impacting a patient and being able to engage a patient to do what they're supposed to do is very difficult, and it's not surprising that the Triple Aim has waited to focus on this part until now. So no matter who it is, and you could say managed care plans, you could say any kind of an insurance plan, any kind of payer, regardless of the line of business, they're going to be citing the same big 3 cost drivers. They're looking at emergency room utilization, they're looking at admissions, they're looking at readmissions. And those are things that when you start to look at value-based care, that those will enter into this. Some of you may even be familiar with a total cost of care or maybe a medical expense ratio if some of your plans are actually sharing that information or talking about that information. All of these pieces actually are attributed to that. In addition to those things, as that's just your high level, but then what happens is as we as a country, we as patients and health plans, as their trends, as the low-hanging fruit is taken care of, and now we reduced our emergency room or admissions or readmissions to where we think we've hit as close to where we should be, then we have to start looking at it a little bit deeper. And we look at the number, but also the reason for the hospitalization, the amount of time that the patient's in the hospital. So how many days are they actually in there? Outpatient services, looking at the cost, looking at who actually orders that, and then looking at provider types. Now, these are things that the health plans are all looking at and have been looking at for a number of years that may or may not have been impacting the physicians and especially the health centers until now. They also look at the drug prescribing patterns, generic versus name brand, and other things that actually impact the cost. So the common denominator in all of this is going to be the patient. So what is driving that cost of care, which patients are driving that cost, and then who they hold responsible. Most of the time, they go to the primary care physician. They look at the primary care physician as the quarterback or the patient-centered medical home. So what becomes what we have to really keep in mind is that how we define a patient. And how we define a patient as a health center versus how it's defined and what you are actually evaluated on from a value-based contract could be two different things. There's going to be overlap, but we have to start thinking about how do we move into a more population health-based patient community. So these are just, the first couple of things, the first 4 bullets out of the 5. Patient comes in and receives any kind of service at the health center. We have a medical record on them, UDS. Basically, it's somebody who's actually, quote-unquote, consumed some type of service at our health center. Well, the last bullet, the person that is covered by an insurance plan that the health center has a contract with and is linked to, and that person may or may not have been seen or treated by the health center. That is who you will be judged on and be responsible for. So your patient is now people that have come in and have been seen within your 4 walls, but then there's also another whole other community out there that is technically linked to you, and we'll talk about attribution in a few moments. So understanding what managed care is about. Now, number one, one of the things I also say is we have to stop looking at managed care companies as being the enemy. I'm not saying that all of them are good or great. I'm just saying is that we have to know who we can work with, but they're all using the same things. They're all being evaluated the same way. How they go about it is going to be obviously slightly different. But overall and in general, patients generally go to the primary care doctor when they're either sick or they're hurt, maybe for a refill of a medication. Something triggers them that they have to go. But managed care companies want the patients to go to the primary care doctor for those reasons, but in addition to that, they also want them to go for at least an annual checkup when you're not sick or when the patient isn't sick. For preventative items, like we say, colonoscopies, mammograms, vaccinations, being treated in the emergency room or have been in the hospital. So those are all of the main items that have actually shown clinically that if these things are done and patients actually do these things, then there is the total cost actually over time goes down. The patient satisfaction goes up, as well as the patient's health goes up. So if you really look into the science and what was done about the 14 or 15 years prior to the Triple Aim being actually integrated into the Affordable Care Act, you will see that there is a lot of scientific evidence to show that the triple aim actually does work when done in tandem and over time. Attribution. So attribution is when the plan actually assigns a patient to your either primary care physician or to your health center. And I'm going to go into a little bit of detail when we go into the preparation of some questions that you really need to be asking and really paying attention to in the information that is shared with you. Sherry was able to share with me one plan that's entering into your market, and I looked at their contract and I looked at their provider guide. Obviously, that hasn't been fully approved yet, but there were some questions that I would want to ask, and I'm going to bring those up throughout when I go through those slides. But in general, for attribution, the patients are that health plan's responsibility. They are on the hook for that patient from day one that they're effective with that plan. Generally speaking, the patient is assigned to a primary care physician using a hierarchy. Now, again, every plan may do this a little bit differently, but pretty much they all do it in some way. They allow the patient to choose. They have automatic assignments if the patient doesn't choose, especially if they're new patients. These first two become very critical. A new patient to a health plan is going to be different than possibly a new patient to you. But understanding that the patient has to choose or the patient is automatically assigned by zip code. And then as an ongoing, if a patient remains with the plan for over a period of time, they use claims data to actually determine who that patient should see. One of the things that you have to ask yourself and ask the health plan is, what are you using to determine who the patient is linked to? Most of the time when they're using the claims, does it have to be an MD or a DO? And is it one time a year? Is it 2 times a year? Does it matter how many times a year? Generally speaking, nurse practitioners and physician assistants, as well as specialist claims, are generally not used to determine attribution. They want them, health plans want them to be used to treat the patients, obviously, but that's a very key point, is understanding what actually allows that patient to be attributed to you. Where are we heading with this? The HHS goals, we have all seen these. Secretary Burwell at the end of 2016 wants Medicare, but this will also be moving into probably other types of arrangements and other types of lines of business like Medicaid and even commercial, where 30% of the traditional payments are linked to an alternative payment model or some kind of a merit-based incentive payment system. As of the end of March, that was achieved. And the end of 2018, they're looking to tie 50% to those models. So that's why it's very critical that we start to really look at this and start to understand it even better. And it does take time. So, patience is going to be a virtue in this. And asking questions. Most of the time it's done through additional reimbursement. This is being paid in addition to the volume. When you get into some of the more alternative payment models or into the more sophisticated, a portion of your payment may actually be at risk. And that's through either shared savings, through capitation, different types of arrangements as you move down that road. The goals of a managed care company are to ensure that the providers that deliver the high-quality care in an environment that manages or controls costs. And again, they're using claims data on the patients, and they're looking at, from a patient perspective, where that patient is getting treatment, how expensive it is, and how often. Care that's delivered is medically necessary and appropriate for that condition. it's rendered by the most appropriate provider and the most appropriate, least restrictive setting. They also want to retain, but they also want to increase the number of patients in the plans because just like with the Affordable Care Act, if you remember, one of the groups or the age areas that they wanted, that the Affordable Care Act really pushes for and wanted to have is that 26 to 39. They wanted that range to actually be the most covered by the Affordable Care Act exchange plans because they were not as consuming of healthcare resources, and their premiums would help to spread the risk. And how they consume health resources becomes versus people younger or older than that, it balances itself out. They want to keep patients out of the hospital. They want to receive and need to receive accurate and detailed billing information from everyone, services rendered and diagnosis coding. They shift more services and payments to the primary care whenever it's clinically appropriate, and that does differ from the total cost of care for their patient. From a health plan perspective, if they see that a primary care physician's total costs are increasing, that's a good thing. They will, because over time, if that trend continues, there should be a decrease in the more expensive things or those items like specialist care and health or ER or hospital. In the past, and if you've had some experience and have had contracts with payers, you probably were part of maybe an approach where they would take on anybody. It didn't matter, especially if they were new to the area. And I think you might be having a portion, you might even be experiencing that now as someone, as a plan is new to the area, some of the regions in your, or even new to a particular region, but may have been in other parts of the state. What's happened is we've actually evolved. Health plans have looked at this, and they actually have started to what they call narrow a network. They want to really develop those relationships. They want to and have started to adjust their business models, and they are changing the reimbursement strategy on how that is happening. They also are looking at new partners to work with, and that includes health centers. From where I sit at the national level, you know, I'm blessed to be able to have some dealings with different national plans as well as some regional plans, and they're all coming to us and want to be able to learn more about health centers and be able to understand, and they know the value and how they can actually understand you better. I use this particular picture to show that when payers are actually looking at developing a network, they generally look at it from their perspective. So they're trying to determine as a puzzle, who fits where, what's going to be the best fit where, not necessarily looking at, you know, everything that the health center might offer. So those are things that you want to make sure that you make that very clear to them exactly what you are offering. So I'm going to go over these 6 areas of preparation. And again, if this is something that you already do, excellent. If not, you know, these are some of the things that I would strongly consider doing. So we talk about the team approach for internal contract review. So I'm not necessarily talking about when you meet with the health plans, having a team approach, although I think it's helpful if you have more than one person be at those meetings from your health center. But taking a team approach, so we have to realize that every person, every employee is going to be either impacted by or has an impact on the contract. And especially as you move into value-based, they all have a piece that's part of that. communication and feedback must be bidirectional. And I would say that you have to constantly evaluate how this contract, this relationship impacts the health center, from the top down to from the front desk staff. You know, if a payer has somebody coming into the actual health center and wants to meet or has information or reports to drop off, you know, is it just a drop-off or is there something meaningful behind it? So it's understanding, you know, if you don't think you're getting reports, maybe you are, but they're either being dropped off and they're in a pile somewhere because nobody knows what to do with them, or, you know, it has to be worked in and looked at and evaluated to make sure that it's meaningful to you. Consistently meet, you know, whatever that looks like. And then the last bullet, is your health center actually prepared to walk away, whether it be entering into a new contract or an existing contract? These are things that you have to be prepared for and think about, you know, are we prepared to do that? Getting to know or investigating the managed care organization. And I would do this for both new and existing. How many patients do they treat? Do you treat? How, you know, when I was talking about the demographics, also look at it from a payer mix. You know, if it's 100 patients for one plan and 500 or 1,000 for another plan, you know, where are you going to put your energy? Where are you going to make sure that you're paying attention most often? Externally, looking at how many patients do they have enrolled? Has their membership grown? Has it dropped? Has it remained steady? How many patients, especially if they're new to the area, how many patients do they anticipate enrolling, especially in those markets that have been pretty, they're not going to be new to everybody. Those have been existing markets, and, you know, the patients and the providers are very familiar with those existing relationships. You know, when somebody new comes into town, you know, how are they as a health plan actually making sure those relationships are where they should be? Also, making sure that you know who the providers and the facilities are as part of their network. You can actually get this information directly from them, but you can go on their websites. You can actually look at and see who is actually in the network. The big piece about that is who's in the network or who's contracted to be in the network is a lot different than who the patients can actually access for care. So you have to make sure when we have that bidirectional feedback from internally, if your front desk or your patient appointment person or is saying, I can't get an appointment with a GI doc for 3 months, that's a problem. And especially as we get into more Medicaid managed care, those things tend to become a problem, and the managed care companies need to understand that as well. So that feedback is very important to give to them. Educating the managed care organization on who the health center is. When I worked for the 2 plans in Pennsylvania, health centers were always part of our networks, and they were especially important to the network. That's because the senior leadership knew and understood who they were. As people start to retire from those organizations, people start to move around or leave, it's important that we keep the people that are at the health plans the understanding of who health centers are. Not everybody's going to know who they are, what they're required to do, that they have the annual reporting of UDS data. They have to have enabling services. They have to have board oversight. Understanding, you know, who we are and continuously do that all year round. You know, the third bullet here, data on patients that were previously uninsured or the social determinants of health. Those things become important, especially the data on patients. If you have a diabetic patient, for instance, and they're now new to a Medicaid plan as of July 1st of this year, but let's say they already had their A1C done. You can share that information back with the plan and that will help to increase their HEDIS and their risk score on that patient. So there are certain pieces of data that you already probably collect that you could actually provide. Patient-centered medical home and electronic health records. Nationwide, we are better than other primary care physician offices in the country, especially with EHR. 97% of all health centers have an EHR, and right now I believe nationwide we're about 75, 72%. So that's a big thing, and that's a big eye-opener to the health plan. Collect all items that are part of the contract, the actual contract, any provider or policy and procedure manuals, fee schedules, pay for performance and value-based programs. They should have information on those programs outside of a contract. And understanding how changes to any of the above are communicated. Will the health center have the ability to opt in or opt out of those? What are the time periods? What are the time frames? And when we're talking about having those consistent meetings internally to review those contracts, it's making sure that we're reviewing all these pieces throughout the year. Read, read, read. When was the last time you actually read your contracts or any pieces of your contracts? You need to read them all, and the entire team should read them. Make a list of what you should have. Make a list of questions, things that are unclear. Even if things are not really what you're not sure, don't assume anything. I say no question is dumb. My thing has always been and continues to be personally and professionally, the only dumb question is one not asked. So if you have something that you're just not clear on, ask. You want to pay close attention to the term of the agreement, number of years. Most contracts from an MCO will have what they call an auto renewal or the evergreen provision. It just automatically continues to roll over. And that means that anything that's been, so if you have a contract with an MCO from 5 years ago and nothing has changed, that's from 5 years ago. So that's why when I say meet consistently and evaluate your contracts and the different pieces to it, that's why it becomes even more increasingly important. Effective date. Looking at your effective date of the actual agreement, what does that mean? Usually the agreement supersedes, or the effective date is prior to your providers becoming credentialed and effective. So most of the time, those two things do not start at the same time. Services, if there's certain services, are they effective with the date of the agreement, or they have different terms as well? Products that are included. Making sure that number one, what the products are, and if they specifically list those out, like Medicaid and Medicare, what does that mean? Ask them specifically the names of the products that are included in that. Number two, making sure, do all the terms of the contracts and all those attachments actually meld or actually are tied to all of those plans? Or is it going to be different for the Medicaid versus the Medicare? That's very important to ask them. And then lastly, the all products clause. This is something that, especially if you are in existing plans, most of the time they will have the all products clause as part of the contract. That means that everything you've agreed upon with that contract, if they add in a new plan under Medicare or Medicaid, or if they also add in other things such as a commercial plan, and it says an all products clause, the terms, the payment, the attribution, the guidelines, authorizations, everything, you have already agreed that that is okay at the time that you signed and the effective date happened within your agreement. So it's very important to make sure that we understand from the managed care company what exactly that means, and for them to be very, very, very specific on that. providers, looking at the credentialing and the time frame. Now, Sherry did share with me the other day that the new language that was included in the Health Choices Agreement, that was a...
Yes, besides my apology, yes. The credentialing language that's included in the new Health Choices contract, effective January 16. Some of you know we've been trying to get the exact language, and we did get that from DHS this week, and it will be in today's newsletter.
Great. Thank you. So I guess I'm hoping that where I got dropped off was the statement that is part of that language, the provider, and it doesn't have to necessarily be part of this, but any time that they say that that the credentialing or the application packet is complete, make sure you know what that means. If there's, I mean, when I worked for both UPMC and Geisinger, we actually had a checklist that was developed. I don't know if they still use it, but we had a checklist that identified and listed out what a complete, down to what had to be signed. So that was what was deemed a complete application. So even though it seems very specific, I would ask them what that means. In general, 60 days is great. That's a really wonderful turnaround time, and it can be done, if not sooner than that. But normally, the health plans, they base it on the signature of that provider that's being credentialed. The date they use is usually the date of that application. And in the past, it's been up to 180 days. So if it takes longer than that to actually get them through the credentialing process, they may need to have a signature again and just do a quick evaluation again. But just to let you know that. One of the things, too, is that knowing what type of provider can actually be credentialed as a primary care physician and who can actually be linked to them as patients. Which type of provider can actually be attributed patients. Panel size, is it per provider or is it total to an actual site or location or tax ID number? You have to be very specific. And does that matter or does that change depending upon the type of plan or line of business? So is Medicaid one way and Medicare is another and commercial is another? You have to, and what I would do is if there are differences, ask them why it can't be made the same. Claims information, authorizations, referrals, timely filing. This has become, and what I keep hearing not only in Pennsylvania but across the country, is they're seeing where the timely health plans are getting better with timely filing. But what's happening is they're actually reducing those days. And I've heard some as low as 45 or 30 days, which, to me is that's really aggressive. Making sure that you're getting that information, and if there are changes to things that are going to impact you, that you know that. ID the services that are included and what can be reimbursed outside of your PPS rate. So are there things that you can negotiate or can carve out to make sure that you are getting so if it's a medical device or something that's being done or let's say a vaccination, what are you actually being paid for? Are you just being paid for the administration? Can you also submit a claim outside of PPS to actually get reimbursement for the cost of that device or that vaccination? Does it apply to all products? If not, what are the differences and why? Here? Okay. This is more on paying close attention to when you have separate or pieces of the value-based pay-for-performance contracts. Is it a separate contract? Is it optional? Is the payment going to be outside of the per-visit payment? When are you eligible for this type of arrangement or contract? So if you haven't met a threshold because they're using membership as that, what are they using? How often are they monitoring that? And do you get to see data and reports and still receive measurement prior to that? Because that would be very important to know, if it's going to be a year before you could possibly be part of one of these arrangements, it's very important to be able to get that data and be able to react to it so that you're in a better position and that you look better as you come closer to meeting that threshold. Measures. What are they using to actually measure that? Looking at the definitions, evaluating time frames, benchmarks. Who are you being compared to? Are you being compared to yourself? Are you being compared to other primary care providers? Are you being compared to other health centers? Where is the information coming from? Is it only coming from claims? Are there other ways or other items? Looking at what the managed care company is going to use to support and bring resources to you to be able to do this. Patients. What patients are actually being used? When you're looking at if they're using HEDIS or STARS for their value-based pay for performance, HEDIS and STARS actually has it would be a sub-population of the entire population on your Medicaid, for instance. So your Medicaid, it has to be, there's what they call a continuous enrollment clause or a continuous enrollment measurement. So it only looks at those patients that have been enrolled with that plan for 12 or 24 months before they can actually be included as part of the measurement. So make sure that you know, is it all of your patients in that plan? Is it a subtotal of that? Clinicians share information across the continuum. We want to be able to collaborate, coordinate the care, using MCOs to do that. They're the ones that have relationships with all these different providers in hospitals in the area. If there is something, if you need ER reports, if there's something you need to do to impact that patient care and to coordinate it better, go to the managed care company. Let them know. Providers and payers to align incentives and mutual goals. They're all trying to take care of the same patients, and they want the patients to be more active in collaborating with their care teams. And they can do that when the patient knows that they're being treated by everybody in a better way or in a more coordinated way. We want to make sure that the access to services and providers are captured. We want the information, the data to impact change. We want to retain and grow our patient base as well. It's very important to do that, especially as you move from uninsured into the insured. How many of those patients are you going to be able to retain because you have had a relationship with them prior, and now they may have a choice, or maybe if you don't decide to sign a contract, how many of those patients are you going to not be able to continue to treat technically from a health plan perspective? From a mission perspective, we definitely treat, and that's another part I meant to mention before, is letting them understand, helping the MCOs understand that you have a mission, but you also have a business, but you're trying to bring the two together. But helping them understand the mission is very critical. I'm going to, actually, I think what I'm going to do, Sherry, if it's okay, I'm going to open it up to questions. One thing I do want to show, I'm just looking at some things. On this slide, the very last thing, remember that your timeline does not have to be the same as the payer. So, they're under a timeline, but you have to make sure that you're not being backed into a corner, or you don't feel like you're being, okay, or that if you do sign, that you have the ability to get out of a contract, or what are those things that if it's not working, what do you need to do to be able to do that? So I just wanted to bring that to your attention.
In relation to that, Jen, if I may add, many of the folks on the call know that we've had an issue with some language that DHS included in the Health Choices RFP, and that if we're not successful in getting out, will be in the contracts, that would prohibit contract pharmacy 340B. So essentially anyone, any patient that is in Health Choices, we would not be able to use 340B for if you're using a contract pharmacy. I know that that language is in at least one of the MCO contracts I've seen. I would encourage you not to sign or to be cautious in signing before we get this resolved. It's one more way to keep the pressure on DHS to pull that language.
Yeah, very good point. Yeah, anytime, and that's using your network and your PCA to help coordinate these things is very important. They really do a great job in doing that, and I think it's using each other in this is going to be very important. So what I'd like to do is I think we can open it up for some questions and discussion. And again, I will make sure that you can share these slides with everybody. I haven't changed anything that I sent over to you the other day, so you can. You're welcome to share them.
We'll be happy to send those out as soon as we have access to our files again. We are in the process of data conversion here, so we're saying our prayers at PAC.
Okay.
And this is Judd. I would also add that if you want to ask a question via chat, you can type that in the chat area, and we can ask that question if you don't want to ask it via the phone.
Or if you have questions that you would like us to include on next Friday's call, which will be more focused on, it'll be much more of a discussion, please just email those to us.
Is there anything in particular that's burning? Again, no, there's no dumb question, and believe me, it's a judgment-free zone. It's not that anybody's been doing anything wrong, or these are just my gut reactions to things. I want to position you, and that's part of why I was hired, was to help position the health centers in the managed care environment and as these changes are coming. So the more dialogue and more questions that we have, it just helps everyone.
Okay, I'm not hearing any, Jen. Please, again, give us your feedback, whether this was helpful, and give us your questions, because we have questions from a few folks that we will have addressed next Friday, but we want it to be as much of a discussion as possible. Jen mentioned about value-based contracting, and some of you probably have not been presented with any pay-for-performance or value-based elements of a contract yet, but I will tell you that it's likely that you will be. And the nice thing is we have health centers, particularly in the Southeast, that have a great deal of experience now with entering into pay-for-performance or value-based. And they are, right now, that's all on top of your PPS rate, and it is an opportunity to enhance revenue at your health centers. So I encourage you to learn from one another, ask questions, look at your any contracts that you have right now so that you have questions for next week, and keep in touch with us. one last opportunity for questions, and then we'll terminate the webinar. Hearing none, I hope everyone has a wonderful holiday weekend. Thank you, Jen.